All right, good afternoon, everyone. It's really nice to see you on the call today. We're excited to be here in our 9th session of our community of practice. We meet every month to focus on ways to better integrate palliative care into humanitarian settings in East Africa. And we're really excited to have each one of you with us today. I've seen a few people introduce themselves in the chat, which is great. Nice to see you, Lamek, and also Yvonne from Rwanda. Welcome. So if you want to take a minute to introduce yourself, you can put your name, kind of what your role is on your team, your healthcare team, and then where you're working. It would be great. We also have Frederick from Ghana. Welcome. So today, during our session, we will be doing our routine of listening to a simple lecture on Pediatric Oncology and Palliative Care in Humanitarian Settings. We will then have time for discussion. So if you have questions, you're welcome to put them into the chat. And also after the teaching time, we will allow for kind of live questions. You can put your hand up. During the teaching, we just ask you to stay on mute just so everyone can hear our speaker. And then after our time of discussion about the topic, we'll go into a case presentation. So then we'll have time to think about a specific case, patient case, and then we'll end in a time of discussion about the case. I'd just like to introduce a few of the other members of the teaching team that are with us today. I see Dr. Zifara Ali is on the call. Most of you must know her. Dr. Zippy, do you want to say hi? Sometimes Dr. Zippy is multitasking, which she might be. So Dr. Zippy has been a palliative care physician and has led the palliative care movement here in Kenya for many years. She's now the chair of the NCD Alliance here in Kenya and is a strong advocate for palliative care in humanitarian settings as well. We're really glad that she's with us. She's based in Nairobi, Kenya. My name is Erin. I'm a palliative care nurse and have been supporting training in palliative care in East Africa through PallCHASE for the last several years. And I'm also based in Nairobi. And today we're excited to have Dr. Megan Doherty. She's a pediatric palliative care practitioner based in Canada and has extensive work in Southeast Asia and Asia. And we're really excited. She's been helping lead and support a lot of education opportunities through PallCHASE, which is a network of providers looking for ways to really increase access to palliative care in humanitarian settings. So we're really excited to have her with us today. She'll be teaching us on pediatric oncology and palliative care. So welcome, Dr. Megan.
Thank you very much, Erin, and welcome everyone. I'm so happy to be with you this morning, or it's morning for me, evening for you. So here are my slides, I think. Okay, good. So like Erin said, I'm a pediatric palliative care provider, and I have a lot of experience with providing care, palliative care in your region through the MSF telemedicine program. So I hope this is relevant for you. So I'm hoping to today just describe some of the common cancers, just so you kind of know what they are and what's the problem and how you could best help the children in terms of giving palliative care, some of the symptoms they have, and how we can help manage the symptoms. So if we think about the common children, we kind of divide it up, and it's a bit different than adults. So the most common types of cancer, you might recall from medical school or nursing college, is hematological malignancies, meaning like tumors or malignancies of the blood. So these are leukemias and lymphomas. Then the other types are solid tumors. We have osteosarcomas and Ewing sarcoma being fairly common, and then brain tumors and other tumors of the central nervous system. And like I said, the most common is leukemias, then brain tumors, and then lymphomas in children. So you can see how that's quite different from adults. Here you can see some of the things we think about that make us suspicious that a child has cancer. You know, they could have weight loss, fever, infections, shortness of breath, weakness, pain in their bones or joints, fatigue, loss of appetite. They can have a lot of lymphadenopathy, enlargement of the spleen or liver, night sweats, bruising, bleeding, etc. And as you can see, all of these things are very non-specific. You know, like just if a child has lymphadenopathy or fever, it's not the first thing you think of that they maybe have leukemia or cancer. First you're going to think about malaria and TB and many other things that are much more common. So sometimes these children have come back to hospital 3-4 times or come to different hospitals before they finally figure out, oh, it's not just infection, it's not just malaria. Actually, this child has another reason for having a fever. So let's look at acute lymphoblastic leukemia. We call this ALL. This is the most common cancer in childhood. So I'm going to spend a bit of extra time so you really know a little bit about it. Okay. So the main problem, if you were to really get down to the most important thing that happens, is that the bone marrow makes too many immature lymphocytes, which are a type of white blood cell. These are called lymphoblasts. Okay. If you imagine this is kind of what normal blood looks like, you got lots of red blood cells, you got some platelets, and you got a few different types of infection fighting cells. These ones are neutrophils, and these ones are lymphocytes and monocytes. So that's what it should look like. This is what it looks like in a leukemia. There's a whole bunch of these lymphocytes, too many, right? And they're immature. So if you have somebody who can look at the blood film for you, they're going to say, there's a lot of lymphocytes and they're lymphoblasts. We often call these blasts, and we say there's blasts in the peripheral blood. That there should not be blasts in the peripheral blood, right? There should be a few blasts in the bone marrow, which is where they're starting from, but they should not get out into the peripheral blood. So this would be, what it may look like. All these purple ones are not supposed to be there. Okay, but don't worry. I'm not qualified to diagnose this, and neither are you. You're going to have some help probably to try and figure out what's going on. Now, you may suspect that the child has leukemia, and that may be as much as information as you get because you see a lot of lymphocytes, and your person who's looking at your slides, your pathologist or your hematopathologist, whoever it is saying, I see a lot more of these than I should, but they're not totally sure. And then you may see that the other cell counts are low, right? Like there's not a lot of red blood cells. There's not enough platelets. So that may be as much as you get for your diagnosis. So like I said, a CBC, a full blood count, a complete blood count is sometimes what we use in certain settings to diagnose, but ideally we use a bone marrow as well. And like I said, you see these lymphoblasts in both. We have certain factors that affect prognosis. So it's helpful to know these because it helps guide you a little bit in your counseling. So if they're 1 to 10 years of age, they're considered standard risk. That means the best risk, but essentially low risk. High risk is if they're over 10 or if they present with a high white count of over 50,000. And very risk is age less than 1 or if they have a poor response to your initial treatment. We'll talk a bit more about what you're going to do with this, but it is helpful to know this because what they do in leukemia is they provide risk stratified treatment, meaning a child who is very high risk is going to get much higher, more essentially toxic chemotherapy. Okay. What that means is that they are at higher risk of dying during treatment. And the treatment's less likely to work. Here, this is showing how they do the bone marrow. This should not be done unsedated in children. Ideally, you should have at least some kind of sedation, but this is what the hematopathologist or hematologist, oncologist would do. They also do a lumbar puncture because we always check for leukemia to see if it's in the cerebrospinal fluid, see if the leukemia is in the central nervous system, because that's a place it goes, hides out, spreads there, and we need to make sure we know if it's there so we decide if we do more treatment that's aimed at getting rid of it. Okay, so this is probably, I don't want to get too technical, but just so you have an idea of what they're actually doing, there are 3 phases of treatment, okay? This takes 2 to 3 years, okay? The first phase is induction. That's where they give the child fairly high doses of chemotherapy to get most of the leukemia cells killed, okay? Then consolidation, which is lower dose but lasts for a few months, is where they're trying to, if there's any remaining leukemia cells, they're trying to get rid of them. And then there's maintenance, where they're trying to prevent any cells from regrowing that might be having the potential to be leukemia cells, okay? So if you stop after induction, the child just relapses and dies. If you stop after consolidation or during consolidation, same thing. Everything goes back to here. And you're back at the beginning, the child goes into relapse and they will not be cured. If you stop during maintenance, same thing. They're going to go back to being relapsed, having active leukemia, and they would need reinduction, the whole thing again, and it doesn't work as well the second time. So the reason I'm telling you this is because the big problem we have is that the induction kills most of the leukemia. So if the child survives induction, they look good. They look healthy. They look like a normal child. They don't have fevers anymore. They don't have bruising. They're not fatigued. So it's very hard for the parents to believe the doctors when they say, okay, now we need to do this for 2 or 3 more years. And then the parents are thinking, why does this doctor want me to do another 2 years of this? He looks fine, okay? And then the child will abandon treatment because parents don't want to keep coming, and then the child will relapse and die, okay? So there is no point in starting unless you have the parents convinced and believing and supported that we're going to do the whole thing, okay? Because if you get here and then the child stops, you have not achieved your goal of cure. They will die. So let's look at what has been happening in Kenya. So I did look last night to see if I could find some studies about what's the prognosis of ALL in Kenya. So this is from 2021 from Eldoret at this hospital. I'm not familiar with it. I hope you guys might be. Moi Teaching and Referral Hospital, MTRH. They must have some, they seem to have a connection and are doing some pretty significant cancer treatment. So they reported on 136 patients, sorry, this should say ALL, over 6 years. Of those 136 patients, they had 27 children complete or continue treatment, as much treatment as they should have. That's 20%, and have 3-year event-free survival. Okay, so what does this mean? This does not mean that 27 children survived forever from their leukemia. There's still a risk that many of them will have a late relapse, but they had 20% who actually followed the treatment plan and were successful. That treatment plan cured them as much as it could. So what this tells me is that even with very good care, even with like standard oncology treatment, what they should have at a center where they do treatment for cancer, really these children need palliative care from the time of diagnosis, because 80% of them are not going to survive. That is very high, right? And that is even with the full treatment. Let's look at the other type of leukemia in children, which is common, which is called acute myeloid leukemia, or AML. Basically, it looks the same as ALL. You're not going to be able to tell just from how the child presents. Remember, there is no staging of leukemia, right? For solid tumors, you might have, stage 1, stage 2, stage 3, stage 4. They don't have stages for leukemias, okay? For AML, we have 7 subtypes and a few other there's a few more than 7, actually. I'll show you. And the treatment is similar. You have the induction, and then you have the consolidation or intensification. So just so you know what we're dealing with childhood AML. So right away, they take off 2 categories here. Down syndrome with AML. Okay, the good news about these kids is they actually do better than standard risk or any other type of AML. And there's this type of AML called acute promyelocytic leukemia. And this has a very good prognosis. This you should consider treating or sending the child for treatment, because these kids can be cured pretty easily. Otherwise, everyone else has what we call de novo AML. They could be low risk, intermediate risk, or high risk. But we're going to look at these children and see that their prognosis, no matter what level of risk they are, is not good. So other than the Down syndrome and AML children and the APL children, which you should potentially be able to identify pathology, the rest, we're just going to give palliative care. Because here you can see, this is very complicated. I don't really know what all these things are, but I'm showing you this to illustrate the point that to determine who is low, intermediate, and high risk for AML, you have to do all these genetic tests, which we are not going to be able to do. So you're not going to know who is in which group, basically. So again, let's look at the prognosis, because that's really going to guide us about what we should do for these children. For AML, there's another study from the same hospital, 2022, from Eldoret, from this MTRH hospital. They looked at 101 children with AML over 8 years. Now, they excluded the APL and the children with Down syndrome and a few other things that don't really count as AML. So we had, in the end, 73 patients who had records available for them to look at in the study. A bunch of patients, their records were lost. So that's how 101, we took out a few with some good types of AML, and then we're down to 73 here. Okay, of those 73 patients, only 2 patients were alive after 2 years, despite treatment. Okay, so I'm going to say it again, 73 patients, only 2 patients were alive after 2 years. Okay, 1 was in remission. The one actually took chemo and got into remission, but the child will relapse because the chemo cannot be given at a high enough intensity in these kind of centers to keep the child from relapsing. Okay, and 1 child had abandoned treatment and apparently was still alive. Okay, so there was actually only 55 patients who started chemotherapy, because of the 73, some patients abandoned before even starting. So of the 55 that started chemotherapy, only 1 patient was alive. Okay, so you start with 101 patients, 1%. So 1% is not acceptable to start treatment. Okay, if you have only 1% chance of curing the patient or even keeping them alive for 2 years, I'm not saying this child was cured, this child was not cured, this child was just alive after 2 years. This is not a good reason to refer the patient or to start treatment, because you cannot put 100 children through treatment that kills them to save 1 child. Okay, so we are not going to be doing this. So these children should just get palliative care from the time of diagnosis. You should not refer children with AML. You should keep them and just give them palliative care. Why do so many children die? Because you're probably thinking, I've heard that this is better, there's more survival for these diseases than what I'm telling you. Okay. Why do children die from cancer even when we do have treatment available? Because unfortunately, to cure someone who has cancer, you don't just need chemotherapy, you need all of the supports that go with it, okay? Because you have to give them a lot of very intense chemo. And if you do that, you need transfusions. They have to get transfusions. If there's not readily available, safe blood and platelet transfusions, they won't survive. They'll die of a transfusion, need for a transfusion. They'll die of anemia or thrombocytopenia, bleeding, etc. You have to have antibiotics. You have to have very high, broad spectrum, strong antibiotics. You have to have antifungal medications, IV antifungals, because these children are highly immunocompromised when they are getting chemotherapy. You have to have an intensive care unit because you need to monitor them. You need to manage sepsis. You need to manage other life-threatening complications of treatment. And you must have social support, financial support, proper counseling, making sure they keep coming back. And if you don't have this, it doesn't matter if you have everything else, because the patients will just abandon treatment because it's too expensive, too long, too complicated for them, unfortunately. So really, what we're left with is that we unfortunately are not in a situation where most of these children can be cured, and we really should be focusing on palliative care. So the good news is palliative care can provide a lot of really important support for families, despite the fact that unfortunately we can't cure the child. So let's think about what are the symptoms that children might have when they have advanced cancer, and how can we help them? So if we have children with leukemia and lymphoma, the most common symptoms you will see when you're giving palliative care to these children is bone pain, fatigue, infections and fevers, and bleeding. Okay, and we'll talk about how to manage each of these. We haven't talked a lot about brain tumors because you probably don't have access to a neurosurgeon. So again, you're going to mostly give these children supportive and palliative care, but they will have, their symptoms will depend on where's the tumor located, do they have disease in their spinal cord, if they've had a hydrocephalus, do they have leptomeningeal disease, a few things. But overall, what you're going to see is seizures as a common end-of-life symptom, being sedated, being confused or delirious. They could have issues with elevated tone, like dystonia or spasticity. They can have paralysis and nausea and vomiting. So just different things you might see. And again, I'm going to go through each symptom and tell us a little bit how to manage. And then with sarcomas and solid tumors, many times we see pain because this is a big tumor that's growing and growing and causing more pain. Sometimes it grows and the skin gets broken down. We get a malignant wound. And if it's in the lungs or in the chest, then we're going to get dyspnea, or we might get metastatic disease, meaning spread to the lungs, which causes dyspnea. So what we're thinking about when we're thinking about a child with cancer is what's our goal or our intent for our treatment, right? And near the end of their life, the goal is not to cure them. The goal is not necessarily to change the course of the disease. Unfortunately, like I've told you, we have to accept that the prognosis is that the child will die, but we're trying to improve their symptoms. So we look at what symptoms they have, probably from those lists, and then what can we do to help, and are there any risks and benefits that we have to balance or trade-offs? So what we're thinking about is this diagram, which I'm sure you've seen something similar before. This is a little bit different, but here's the time when the child gets diagnosed with cancer right here, right? And then maybe there's some curative or life-prolonging treatment, although like we've talked about, that might not be an option in most of our settings right now. So mainly what we're going to have is palliative care, which is in yellow here. And the palliative care is going to provide symptom management. And I think for many of us, the children are going to already present once they're much closer to needing only palliative care, right? And then we're going to see that they get sicker. They might be what we call close to the end of their life, life closure, and they might then move into the end of life or the dying phase. And so the palliative care is really a large portion of what's going on. There's not a lot of treatment focused on prolonging life at this phase. But then the important thing is that after the child dies, we continue to provide bereavement care. So some of the things we have to do is help families know when their child is coming near to death or near the end of their life. So most people, and even most children, look the same when they're coming near to the end of their life, whether it's from cancer or non-cancer. So you will, if you provide palliative care, you will recognize the pattern of what you're seeing when a child is near end of life. And most families do appreciate honest information about the changes that we are seeing. So we usually ask the family, separate from the child, how much information about what's ahead do you want from me? Do you want me to tell you when I think things are changing and where I think he's at, how much time he has left? Ask permission to review the changes so that you know if the family wants it. But 90% of families do want that information from us. Now, we have to refrain from making very firm predictions on time. Just give a range, okay? Because if you say, oh, this child can't live more than 2 or 3 days, you're going to be wrong. Even me, I can't predict that closely how quickly a child will die. But if you observe clinical changes hourly, then you would expect death in hours to several days. If you see changes daily, then death is expected in days to weeks. If their changes are weekly, then death is more likely weeks to months. Now, the most important thing is, what changes are you looking for? You're looking for changes in energy level of the child. Like, are they running, playing, or are they sitting? Are they just in bed? Are they sleeping all the time? Like, are you seeing changes in that? You're looking for changes in eating. Are they eating normally? Are they eating less? Are they eating almost nothing? These are the main things that help you. And then you're looking for changes in symptoms. Are they having a few symptoms that are stable? Or are they having new symptoms quickly? And every day you're having to change medications because the symptoms are getting worse. Like the child's getting more pain every single day and it's worsening. And here are the common symptoms that we see at end of life in children. Almost all children have fatigue, physical fatigue. They stop running, playing, getting out of bed, sitting up. They just rest. They lie in bed, especially children. This is for children with cancer specifically. Again, most children with cancer who are dying have pain. They have poor appetite. They have nausea, vomiting, swallowing problems, constipation, and shortness of breath. Okay, this is all types of cancer combined for this study. So you can see they actually have quite a lot of symptoms. Children with cancer have more symptoms at end of life than other children. So here's a few of the symptoms. Let's go through some of the key ideas about how we manage each symptom as it comes. So agitation, in the last 48 hours or the last few days of life, you don't know the last 48 hours until after the child has died. You don't know what the timing is. But it can be distressing for families. Their child can be very confused or agitated. Some children become very sleepy. Sometimes it's due to increased carbon dioxide levels because they're not breathing very deeply, increased intracranial pressure. And what we need to do is explain that this means that time is getting shorter. If the child's agitated, we try and provide as calm and quiet an environment as possible, make sure the patient's safe, they're not going to hurt themselves or fall, and counsel the parents. Tell them to talk to their child, but don't insist on correcting the child. Like if the child is persistently confused about a certain thing, like they keep saying, I'm at home, you don't have to correct them. You just say, okay, yeah, you're at home, even if the child is in the hospital. Sit next to the bed or cuddle with the child. The parent's presence can help orient and soothe the child. Remind families their loved one can still hear, smell, and feel them. So being present, talking, reading, singing, praying, all these things provide comfort to the dying child. We also use medications to help with agitation if needed. The most common ones would be haloperidol and olanzapine, depending on what's available, and benzodiazepines. And this table is just a reference for you, shows you each of the antipsychotic medications that we use, how much does it block each type of receptor, which is sometimes very useful. Obviously, you want a lot of blockade of what we call dopamine receptors because that causes people to be more sedated. Pain can be quite common, as we saw in the last 48 hours, depending on the illness, the location, the disease burden, etc. So we ask the child about their pain. If they can't speak or they're not able to communicate, we look at their face. Is it grimacing? Is it relaxed? Look at their arms and legs. Are they clenched or are they relaxed? That can help us. And opioids are the first line. Of course, we can't get into all of that today, but we use morphine first for children. And these are the routes and the dosing. I won't go over all that. Many children with cancer develop dyspnea in the last weeks of their life. And this is a scale that we can use. This is called the Dalhousie Dyspnea Scale. You can use this scale to help children tell you how much dyspnea they're having. A little bit like the FACES pain scale for pain. But this one is for dyspnea. And this was developed by interviewing children who had dyspnea and asking them to draw what it looked like. Now, these are lungs. Okay, most children do not know what their lungs look like. So you're going to have to explain that this is their chest, this is their lungs, this is what it feels like. Oh, sorry about that. So we use a lot of non-pharmacological measures to help with dyspnea, especially a fan, repositioning the most comfortable position. Sometimes you use a humidifier if the air is very dry. Try and open a window, have air movement through the room, avoid overcrowding the patient. But we don't usually use oxygen because most children do not feel it helps them. And we're going based on how the child feels, not based on the number that their oxygen saturation is, right? Because every child who is going to die, like their sats are going to go down at the end of their life, right? That's how you die. So you don't just put oxygen on everybody because it doesn't make a difference. It doesn't make people feel better, and it doesn't change how long they live when they are in the end of life phase. We use medications. Opioids are the first line medication for dyspnea at 50% of the starting dose for pain. And benzodiazepines are the second line, and I've given some dosing there. Oh, I'm coming to the end of my time. Sorry, I've just got a couple more slides. We often see excessive secretions or what we call congestion in children at the end of life. Sometimes we call this noisy breathing. It's when their secretions pool in their upper airway. And this can be very disturbing to families, although it's usually not painful, not distressing to the child themselves. So again, we look at the child's face. How do they look? Do they look relaxed or tense? Look at their arms and legs. If the child looks very relaxed, then we do things like we just turn the child on their side, allow the secretions to drain out. We don't suction them. We might use medications that help dry up secretions. Many times we get questions about transfusions at the end of life because children with cancer, when you're diagnosing them, sometimes they've been given transfusions because they had very low blood counts, very low platelet counts. So we have to transfuse the patient balancing the risks and benefits. Okay, so we may transfuse the child blood based on symptoms, okay, because blood transfusions do tend to help children have less dyspnea. So we can try a blood transfusion for dyspnea to see if it helps or worsens the symptoms, right? Because as a child comes to the end of life, the body slows down, and sometimes the fluid of the transfusion actually goes into the lungs. The child gets a bit of pulmonary edema, so then that makes the breathing worse. So sometimes we're hesitant, the transfusion might help, it might not help. So we may talk about this with the family, might say, okay, we're going to try a transfusion this time, but if it doesn't help, we're not going to do it again. And sometimes the family needs to see that and see the child actually see that the child doesn't get better with the transfusion. We do platelet transfusions for symptomatic bleeding sometimes because there could be a lot of bleeding from the mouth, the nose, the mucosa. Sorry, I think my slides are automatically going forward. And then lastly, we'd look at malignant wounds where the child might have pain, odor, bleeding, infection from a wound, and it can be very distressing for the child. So we do have to make sure, and this is where the nurses on our teams are so important, we have to make sure we do good wound care. We provide pain relief like morphine before we do the dressing change. We clean the wound with only clean boiled water or sterile water because this is the least painful, and also it keeps the skin healthier. We don't use betadine or providine or anything that is cytotoxic. Those things should not be used on open skin or wounds. We use Vaseline to help the dressings not stick to the wound. So I would use a lot of Vaseline so that there's no sticking, because if you peel the dressing off and you pull any skin off, then you really will cause more bleeding. And these tumors are very vascular, so they bleed a lot sometimes. We use topical crushed metronidazole tablets if the wound is very odorous. So you put that on the wound and it kills the bacteria that are on the skin that are causing the odor. And we can use topical crushed tranexamic acid tablets for bleeding as well, or you can use, you can apply epinephrine or adrenaline vials, like the liquid, injectable liquid. You can open the vials and apply that topically as well. Again, that causes vasoconstriction and reduces bleeding. So this is just one slide to give you a basic wounds, but of course it's a much bigger topic. If the patient wants to go home, we would send them home with some medications, okay? Because if they call you once they're home and they have nothing, it's very distressing. So we send with lorazepam or midazolam, one or the other, which we can use to treat delirium, seizures, dyspnea, hemorrhage. We send with morphine for pain and dyspnea. We send with methotrimeprazine. It's very similar to haloperidol. So you could send them with haloperidol, again, for nausea, vomiting, and delirium. And then we send with something for secretion. So we have atropine eye drops, which we use in the mouth to dry up the secretions. Other medicines that work in this way are scopolamine and hyoscine, or scopolamine, which is hyoscine, or glycopyrrolate. So you may want to adapt something like this and have a plan, 3 or 4 medicines that you send the patient home with if they go home, and a plan that they're going to call you, and then you would explain to what to do. I would never give them more than 3 or 4 medicines because they will get mixed up. So 3 or 4 is plenty. After the baby dies, what do? We just allow time for the family to be with the body. We ask them what rituals they want based on their religion and culture. We ask, can we remove any IV lines, any tubing, anything that's on the child's body that's medical? We allow the family to bathe the body if they wish, dress the child how they wish. Then we help with transportation of the body, either to the morgue, the funeral home. Many times in many cultures, people just bring the body home with them and bury the child back in their village. Ideally, we assist with that transportation in some way. If you have a counselor or social worker or psychologist, someone in your facility who can meet with the family and give some counseling and support, that's very good. And then for bereavement care, the minimum that we do is we make a phone call from ourselves, from the palliative care team, or from the person doing palliative care to the family several weeks after the child has died, just to check in and say, we're thinking of you. How are you doing now that, it's been a couple weeks? And usually in most cultures, there's a specific time, right? There's a ritual of how much time is appropriate before you call, maybe after all the ceremonies have been completed. So that's a summary, sorry for going a little bit over time, Erin, we talked a lot about leukemia in children, about how we diagnose it and how we treat it, and really that we should focus on palliative care. And then we went through some of those symptoms that we see in children with advanced cancer and how we manage them. So I'll stop there and allow for questions.
Thanks, Megan. Thanks for going through that. I think it is really important that we focus on what can the teams do in the settings where they're working. And I know that we have quite a few people on the call with us today. So we'll open it up to questions. There was a few comments in the chat, but not a specific question so far. Someone mentioned that I think that they've seen Wilms tumor in their settings. Dr. Sippy just stated that children's palliative care, pediatric palliative care still is a pretty big issue in Kenya and a challenge. And then maybe related to one of the symptoms you were talking about, someone mentioned increased intracranial pressure, maybe causing some distressing symptoms to patients. But would anyone have a question related to the general topic today? You're welcome to unmute. We're can spend a bit of time talking about this, or if someone has a patient situation that's kind of come to mind.
Yeah, and I definitely didn't go over all the types of cancer. That's 3 or 4 hours to cover everything. So I just thought I'd go over leukemia since it's going to be the most common thing you see. And a lot of times you're not going to know what the other tumor is, right? You may suspect Wilms tumor, but not know for certain that it's Wilms tumor. The case is going to be a child with an eye tumor, and that you'd think, okay, that's got to be retinoblastoma, but that could also be neuroblastoma that presents with proptosis. So, or AML sometimes presents with proptosis as well. So, yeah, what the hard thing is, you may not know what you're dealing with. Very commonly, I do all the consults for MSF. Very commonly, we're not totally sure what the type of cancer is, but we think about, okay, if we refer the child, what can we do, right? And so I want you to take away that you should not necessarily refer the children with ALL and AML, with leukemia, because they're not going to get cured. It's very sad. I don't like to have to say this, but that's the reality, right? So we don't want to put the child through extra suffering, the family through all this, spending all this money going for all this treatment when it's not going to work for that child.
Abraham has just mentioned in the chat, I think just related to just general children's palliative care in their setting. Abraham, I'm sorry, I'm not familiar with where you're working, but you shared that you have a lot of CP children. Do you want to explain a little bit more about that, Abraham? Or do you have a specific question of how to support? A question for Dr. Megan?
I see someone's asked about tranexamic acid. I can just speak to that as well. So if the child has or anybody, it can be adults too, same thing. If they have a bleeding wound, where there's a lot of bleeding from the wound, because these wounds are very vascular, right? If a child has a malignancy that's untreated, and then we'll have a huge fungating wound, then you apply tranexamic acid on the wound. Okay, so you're doing the wound care as a nurse or even as a physician. I do wound care too. You would either crush tablets of tranexamic acid and apply that to the wound directly, or you could open injectable vials of tranexamic acid and apply that topically on the wound. And you can do the same in the mouth, because children with leukemia often get mouth sores and they get tons of bleeding. Like they just keep oozing blood from their mouth. It's really distressing. And so you can apply tranexamic acid injectable solution to gauze and then put it in the mouth to help with hemostasis. Yeah, okay, you don't have tranexamic acid. If you don't have it, don't worry. Then yeah, you can use adrenaline, same, because it's a vasoconstrictor, right? So it's going to close those little blood vessels. So yeah, you can do the same thing with adrenaline as with tranexamic acid. You can also use sulprophate, which is another medication that comes as a tablet that has similar effect.
Dr. Megan, I know that in some of your community projects in Southeast Asia that you guys also do support children with developmental or neurological challenges. So for the comment related to CP children, any basic thoughts of how to support children with those diagnoses in limited resource settings or in humanitarian, like refugee camps or communities where they have limited access?
Yeah, definitely. So those children with cerebral palsy, we definitely see them in refugee camps, and we see them in settings where resources are really limited. And they're very much hidden patients, right? Like many times they don't come to hospitals. They are more at home, you know, left in the room, on the bed, in the corner, a little bit neglected because nobody knows what to do with them. So the things they often need is looking at bed sores, looking at areas of pressure ulcers, and then helping know how to feed the child best and avoid like a lot of respiratory infections as a result of aspiration from feeding them when they're not very safe to feed orally. So we often help with making equipment, just very basic equipment. It can even be made out of like cardboard and, you know, wood, just very simple things that help the child sit better so that the mother can feed the child better. Teaching the mothers a little bit better how to feed the child. It's kind of beyond what I can explain everything today, but I can put some resources in the IECHO about how to manage children who have neurological problems. But yeah, definitely can be really challenging group, and they're quite different than children with cancer. You know, children with cancer are going to come into your hospital, going to be very unwell, you know, have very low blood counts, you know, have infection, have fever, and without treatment are honestly are going to die quickly. You know, they're not going to live for that long. But a child with cerebral palsy, they might kind of live for quite a bit longer, might get better and then come back, get worse, etc. So it can be quite different experience.
Yeah, I think in some of the settings where you're working, where we have some of our communities who've been displaced for many, many years, it can be helpful to find ways to support a family knowing that they're kind of on a longer term journey. So just continuing to support families to kind of choose a clinic that they will regularly come to, develop that relationship with some of the primary care providers can also be really helpful, I think, for cerebral palsy patients. Which sometimes is difficult when people don't have easy access to healthcare, but okay, so also in IRC. So IRC is one of the main healthcare providers in the Dadaab refugee camp, and they see a lot of patients with CP in their camp. So oftentimes with some of these chronic illnesses, as Dr. Megan was saying, the patients may have situations where they have an infection, or so that they're admitted. Maybe that's the first time we've met them, but they've been dealing with the disease for many years. And I think in those kinds of situations, if there's ways that you can get the primary caregiver connected and feel like they are getting a little bit extra support, it can be really helpful. And if your clinic has potentially even after hours, a phone number or something like that, where I know home care is not often very developed in our settings where we're working, but where the families feel like they can reach out to healthcare providers to get some extra support can also be really helpful for the families and the caregivers. Okay, why don't we shift on to the case? I see we've had some good discussion here about how to support and do some symptom management. Megan, I will, actually I have it, I downloaded it, so I can share my screen. So we're going to be using a case that was shared a few years ago. If actually now is a perfect time, as many of you participants are on the call, we're still looking for case presentations. So we have 3 more sessions in our full year program. And if you're interested in writing up a case of a patient that you've seen that you anticipate could benefit from palliative care, even if you don't have a lot of palliative care resources in your area, I'd love to work with you to write it up as a case, and then you can share it in our, we have 3 more sessions coming up. So I'll be teaching this case or presenting this case today. So I'll introduce the case to you. So this was of a 6-year-old patient who had advanced cancer. So we're continuing on the theme of pediatric cancer diagnoses. So the patient had an enucleation of the right eye several months ago at another hospital, not in the hospital where we saw the patient. The family was advised for chemotherapy at the time, but could not afford to travel to the capital city for treatment. So fairly common situation that we often would find ourselves in, where they may be recommended for further treatment, but there are barriers to accessing that treatment. The patient presented in an MSF hospital with evidence of the tumor progressing in the right orbit, abdominal swelling, as well as being severely malnourished. So the patient had a limitation of opening their mouth with foul breath and difficulty swallowing. So with our limited ability, we did have a differential diagnosis of advanced cancer. And in this situation, we were considering retinoblastoma or neuroblastoma. So as the team continued to consider the case and come up with a plan, they decided to initiate palliative care due to the advanced cancer and assistance in terms of determining the benefit for an NG tube. So it was at this point that the team reached out for telemedicine support from the palliative care, pediatric palliative care specialist. And in this case, it was Dr. Megan. So in situations like this, I'll actually stop sharing my screen because I would like to go, this is a bit of a shorter case for today, but in situations like this, when a patient has advanced cancer, as we talked about earlier during the lecture, when there is identified that there's no chance to cure, given the access to treatment in the surrounding area and limited access to resources to get to facilities, it is really important that information is shared to patients in a compassionate way. So in this situation, the news about this very difficult information was shared to the family in a compassionate way. So the team used a Smikes method to share the fact that the cancer or the disease was very advanced and there would be no chance for cure for this patient. After that type of compassionate communication was given, the team decided, it also advanced on me. It focused on quality of life and symptom control. So the team looked at nutritional support, focused on comfort, and decided not to do NG tube feeding for this reason. The NG tube could be needed for medications for symptom control if it was necessary. So once the communication with the family was given and they were told about their diagnosis and a prognosis was shared with the family decided that they wanted to go home so that the patient could be surrounded by their relatives and their family. So for this patient, in terms of symptom control and home care planning, to achieve the symptom control, they provided support for the patient related to their pain and wound care in the hospital. And then As they got ready for home care, they decided to manage the pain continually with liquid morphine, so 2.5 milligrams, as well as so it was given by syrup as well as an injectable formulation that could be given into the patient's mouth or cheek. Low dose 1 milligram of dexamethasone was also prescribed for the abdominal pain. This was a low dose so that it would really reduce the effects of any side effects on the patient. A course of oral antibiotics and antifungals were given, as well as recommendations for good mouth care, which really improved the mouth appearance. And crushed or liquid metronidazole was given for the smell of the wound. And then wound dressing was given for the tumor on the eye. When the team was doing counseling about the patient going home and needing to continue to access good pain control, this is a tool that was developed several years ago and was used. So a fairly easy tool for patients and families that may have limited literacy levels, understanding to pour some of the liquid morphine into a small cup, then without the needle, using a syringe to draw up the medication for the amount that they were told to take, pushing the morphine into the child's mouth, and then putting the remaining morphine back into the bottle. This is a very easy way to teach and support families taking morphine at home. Another way to do it is also here with even limited writing. So just using images and pictures to teach families about how and when to give morphine. So to give morphine every 4 hours, in the morning, midday, mid-morning, then at 3 o'clock, at evening, and then at nighttime. The 11 p.m. dose, we often recommend giving a double dose so that the child is able to sleep overnight and doesn't need to be woken for the 4-hour dose. Hello. Oop, okay, sorry about that. So how, in this situation, the team had to continue to counsel the patient related to, not the patient, sorry, the family and the caregivers, to explain why reduced needs for fluids and foods often happen when patients have advanced cancer. So giving the patient fluids can cause more discomfort, especially for children with advanced cancer, such as this patient. So IV fluids and even NG nutrition don't prolong the life when patients have this type of advanced cancer. And the risks include respiratory distress, which Dr. Megan had mentioned earlier. Some patients even experience vomiting or fluid accumulation in their abdomen and edema. And this often causes more discomfort and pain to the patients. So during these situations, and especially as patients are being discharged, the team can continue to counsel and encourage and teach families that children should really only be encouraged to eat for comfort, and in really encouraging the child to eat what they want to eat. For the families that, not necessarily in this case, but families that are very interested and very insistent on artificial fluids, trial of hydration can be symbolic, especially in certain cultures, and really continuing to counsel parents about the risks and possibly adding more discomfort to a child. Obviously, doing this in a very sensitive way is really important. So really emphasizing that fluids are a trial and should be stopped or weaned off if there's no improvement. And then continuing to emphasize the goal of care is comfort for the child during this phase. For parents, especially in this situation where the patient was being discharged home, the family wanted to go home and spend time with the patient and the family surrounding them. Really telling parents what they can do can be really effective and really meaningful. So emphasizing the active role that parents can take, especially in doing mouth care, moistening, using a moistened cloth to provide water or juice to the child, gently brushing the tongue or the teeth to really provide good hygiene, and then using Vaseline to keep lips moist can be really helpful. In these moments, especially if we're discharging patients and there isn't a home-based palliative care program that they can access, continuing to support patients and families by acknowledging that it can be really, really difficult for families to see their children's appearance change, and supporting them through that. So being very sensitive and empathetic towards them is also really important. So we'll put some time now as we come to the end of our session today for questions related to this case. So again, it was a 6-year-old patient who presented to the MSF team in fairly late stages and identified that palliative care was the best approach to provide support to the patient and family. And then they decided to go home for further support of their kind of local community. Does anyone have questions or comments? Dr. Zippy, I know you were there. Are you available to comment a bit on this case from your experience? I know actually Pamela is also with us. Megan, did you meet Pamela yet? Pamela is going to be representing MSF. I think she's traveling to Somalia next week, I believe. She's going to be also doing some pediatric palliative care. Pamela, do you have any thoughts or comments? She's been working in Eldoret actually for many years.
Oh, great. Okay. Just to say that if you are at an MSF facility, you can request a pediatric oncology and a pediatric palliative care telemedicine consult, and especially for the ones that are not leukemias and lymphomas. I mean, you can definitely request for leukemia and lymphoma, but you may now know more what to do with those kids. But for the other solid tumors, if you're not sure what to do, just request a consult, and myself and Dr. Natasha, who's a pediatric oncologist and palliative care physician, will get back to you right away and give you advice about, for that child, what you should think about and what you should do, because it's a lot to understand all of this stuff about chemotherapy and stuff. And you can see in this case, we gave steroids, which I didn't mention in my presentation, but they do help. You know, like sometimes they shrink the tumor a bit, they buy you a bit of time with minimal harm. So there's suggestions that we would have that are a bit more detailed. But I think this case is so realistic because this is exactly what happens. They go one place, they get one set of advice, and then they come to you later and they've already had some advice and some treatment, and it's confusing to know what to do because they're like partially treated. You know, this child had an enucleation, meaning the eye was removed because of the cancer, thinking, oh, that's curative. But again, you see what happened, and the child progressed in the disease, which is exactly what happens if they don't get chemotherapy, usually in combination with surgery. Few exceptions, like Wilms tumor, which I'm glad somebody mentioned, stage 1 and stage 2 Wilms tumor, surgery on its own without chemotherapy can be curative, but you may not know if you've got a stage 1 or stage 2. You have to have guidance about what the staging is, right? So a few things like that are tricky.
I see a question in the chat, especially related to working with an international NGO and how to support children and families. So for healthcare professionals, it becomes difficult when there's no such support forthcoming for these families. How do we handle it? And I think this question may be related to the CP patients, where it's more of a chronic illness, but we know also in our pediatric patients, there can be a huge financial burden and a lot of pressure to know how to support, and if families should try to raise money to get to a treatment facility. I would actually put the question back to you, Frederick. I'm also pretty interested to know what your thoughts are on how international NGOs can really support these families. We've been able to work with several, but I'd be curious to see what your thoughts are on how NGOs in your area support children with chronic illness, either like CP or with serious advanced cancers. Do families get support? Do they get a case manager? Are they able to access some of the community supports that NGOs are offering? I'm curious to know. I'm putting the question back to you, unless Megan, you have an amazing answer.
I mean, I think your big takeaway from today should be children with, don't tell them to raise money, don't tell them, because you're not getting good results.
Mhm.
You can't, you know, the thing that happens is that instead of having the hard conversations, people just refer the patient, right? And I don't think that's good care. Have the hard conversation, tell the family, look, I have a study here from Kenya, from our situation, you know, it's not going to work. Your child is not going to get cured if I send you up the road to the next facility, right? So that they don't waste all their time and energy on that. And healthy children in the family who have the potential to go to school, maybe have a different life, and they lose that if the parents spend all the money on the child who's going to die no matter what they do.
Mhm.
So it's a terrible choice you have to make, but making a hard choice is a loving choice for the other kids.
Mhm. Fred, are you based in Nairobi, or are you based in sorry, not Nairobi, I meant Kenya. Are you based in one of the refugee camps that we've been working with?
Yeah, hello, good afternoon.
Hey,
I
Fred.
am based in Ghana. I work in a
Oh,
teaching
Ghana.
hospital.
Okay,
Yes,
okay.
please. So for most of these patients, it is the healthcare providers that contribute money to support them most of the time. But the issue is, how sustainable would this be?
Mhm.
That is the question. That's how come I'm looking for any international support for these patients and their families.
For the CP patients, or you're thinking about the oncology patients, or both?
For the CP patients,
Yeah,
that's
for the
both
CP.
pediatric and adults.
Mhm. Yeah, I mean, there are some, maybe Megan, Dr. Megan and I, along with Dr. Zippy, could see. I'm not so familiar with Ghana, but I mean, there are some very strong international NGOs that are supporting patients with disabilities, such as CP. I think, yeah, there's not a lot of good solutions because these illnesses do require a lot of resources to take really good care of. Do you find your patients are in hospital much, or are they being treated in the community?
Most of them, they are on admission, so they stay longer and they need a lot of financial support.
Mm-hmm. Yeah. Well, let us get back to you, Fred, related to that. We also do have a colleague right now that's working in Ghana, Dr. Kayla. She's a Canadian physician that's trying to support better access to palliative care through training, through, I don't know if you know her, but I can also connect you with her after the session. Are you on the WhatsApp group, Fred? Oh, perfect.
Yes, I'm on the WhatsApp group. I've
Okay.
shared my email
Oh, I see
via
it
the
here.
chat.
Yeah, perfect.
Yeah. All right.
Okay.
Thank you.
Oh, Pamela said that her computer is having a problem. She's trying to unmute, but it's not working. Anyways, actually, Pamela, maybe when you're back from Somalia, it would be great to hear about your trip, because I'm sure we could also learn quite a bit from your teams and how they support children in those settings. Megan, there was one other comment from Rita, said that usually nowadays most surgeons prefer that patients with Wilms tumor get chemo first or after, but they do get it according to the guidelines. So maybe that's part of the team in Eldoret.
Two competing protocols for low stage Wilms tumors.
Mm.
So they usually choose one or the other, which is either chemo followed by surgery or surgery followed by chemo. So, but your team in Eldoret is good. I remember meeting them somewhere at a conference. I cannot recall where, but they are, they're following good practice. But I wouldn't really encourage them to treat anybody with AML. It's just a really hard disease to treat. It's very, very hard to treat. I've not had any success. So.
And I'm not totally sure at the moment, we'll probably wrap up shortly, but I'm not sure if actually in Kenya, if we actually can get our patients referred, pediatric patients. I don't see Annalise on the call, but I saw one of the other providers that's working in Dadaab. Oh, maybe he dropped off the call. But I actually don't know if we can. I don't know if they qualify for referrals here in Kenya. But there are a few projects that are coming up. There was a team, at least for some of the other childhood illnesses. There's a cardiologist and a cardiac surgeon from Aga Khan that's trying to support some referrals for surgery for patients with congenital defects. And I know that that is a really recent program. So I'd also love to find ways to get them more connected in our group. As I think they've now provided at least 10 or 12 surgeries for children in Dadaab that required it. So yeah, really interested to see. I was quite curious to know what palliative care support they were giving to the families who didn't and weren't able to access the surgeries. And I don't think they had a lot of resources in place for that. But I think that's probably where our teams can come in and support. All right, well, thank you. Thanks, Dr. Megan, for your support. Thank you for continuing to teach our group and also be here for questions. And yeah, looking forward to seeing you all. We have 3 more sessions in this program. We've been running it for about a year. And we are keen to see you all in July. So it will be the 3rd Tuesday. I believe it's July 16th. Yeah, we'll see you guys then. Thanks, everyone. Oh, let me quickly put the feedback form. I always forget.
Thanks, everyone, and good luck. And if there's anything we can do, I put the link for or the information about Handicap International. They're the ones who've done the most projects in refugee camps for children with cerebral palsy, like kind of more rehabilitation type projects. But yeah, no, these are gaps and we have to keep talking about it so that we can actually get more care for these kids.
Thanks, everyone. I'm just going to quickly put in a feedback form. If you're still with me, give me 1 second. But thanks again. We'll see you next month.
It's working. I made it work.
All right, if you're able to, I've just put in the feedback form. Thanks, everyone. See you next time.